Hi, everybody. We are very excited to be here today for this webinar. Thanks for joining us. I am joined by some really great colleagues and are excited to talk to you about care team collaboration and a platform that we developed over the last 15 years at Penn, how we use it, how it helps or doesn't help us, and have an opportunity to ask some questions afterwards. Just as a quick agenda, I'll start with introductions, give everyone a chance to introduce themselves, quickly touch on the problem that we worked to address, how we addressed it, and then hand it off to my colleagues to talk about how it has impacted their workflows and their different roles taking care of patients. So starting with introductions, my name is Suba Aranjavia. I am a practicing hospitalist at Penn, where I've been since residency 15 years ago. I'm also an informaticist, and I used to be an associate chief medical informatics officer for the health system. My area of interest over the last 15 years has really been around designing and developing technology to make it easier for frontline clinicians to do our job well, so that we can make less errors, provide great care, and have a better experience doing it. And that has really been focused on transitions and workflow and communication. Margot?
My name's Margot Cohen. I'm also a hospitalist at Penn and work in medical education as one of the clerkship directors for the Penn medical students.
Great. Carissa?
Hi, my name is Carissa Livingston. I'm a PGY3 internal medicine resident at Penn.
And Nick?
Hi there, my name is Nick Cool. I am one of the current chief medical residents at Hub, also at Presbyterian Medical Center. I just finished about a month ago my residency in internal medicine here at the Hospital University of Penn.
Great, thanks. And I did leave off on one of my pieces of the introduction, which is important from a disclosure perspective also, is that I am, in addition to practicing part-time hospitalist medicine, I am founder and CEO of CareAlign, the company, which is a spin out of Penn Medicine based on the work that we did. Okay, so I'm going to go through the problem and why we think it happens, and really the solution pretty quickly, because I wanted to leave the bulk of the conversation for Margot, Carissa, and Nick to share their experiences. So we will go through this fairly quickly, but I thought I would start with a patient story, since that's where all of us are really driven to work. But this really started a while ago with a patient who was admitted with pneumonia. And on day 4, her intern came in with his printed list from the EHR and said, I think she's ready to go home today based on all the things that we've been talking about as a team. There's always immense pressure to discharge patients by a certain time of day. So he said, oh, I'm going to be on top of it, put the discharge order in and get this coordinated, which he thought he had the green light to do. A couple hours later, the attending came in with her printed list and said, you know, she doesn't look as good as I'd hoped she would on the day of discharge. I remember there's this history of a GI bleed. We should check a hemoglobin before she goes home. So the attending wrote this on her paper list that she wanted to check a hemoglobin, left the room to find, call, text message the intern to say, let's check a hemoglobin. But before she could do that, she got called into an emergency with another patient. So this really important message and reminder is now trapped in her pocket where nobody else can see it. They all see the discharge order that was placed in the chart. And sure enough, the patient ended up getting discharged by noon, but promptly had a GI bleed at home, ended up needing to get readmitted, had a long protracted stay. And you know, it's safe to say that everyone was really doing their absolute best to provide the best care for her, but this was not the quality of care that anyone really wanted to provide, and certainly wasn't what she expected to receive. So these kinds of communication failures are really what prompted at least our team to get interested in working on this, especially when we see that communication failures are at the root cause of the vast majority of errors that happen. This is just looking at sentinel events that are reported to JCAHO and how they attribute what contributing factors are to the events. But really, that's the very tip of the iceberg of what is actually happening in medicine. There is a whole, another section of errors that are happening that I think of the visible part of the iceberg that are like near miss events, things that we almost accept as a status quo, like a delayed schedule or eyes and O's that are inaccurate or something else. And we just kind of like it. That's just the way things are. And then there's this whole part of safety and errors that we actually have no idea that are actually happening. And it's really hard to have true measurements of errors, near misses, potential errors. which really is scary, I think, to many of us. So what are some contributing factors to this? I'd like to say this one is a positive instead of as a negative. People often talk about transitions and all of these things as being bad, but really it's kind of great that care has shifted to being much more team-based in the last several decades, where you can leverage a lot of different people's expertise, but it makes it harder to coordinate. It's not, and you really have to rely on distributed knowledge across many different people, since one person doesn't know everything about a patient. And it's not just one team, it's a lot of different teams. So, in many different settings, one patient can go through many different teams just in a couple of days, especially if they're transferring between units. And it's also really important to think about the team, not just as the medical team, but the consultants, the nurses, the therapists, the pharmacists. There's so many people involved in caring for patients that we really need to all be on the same page. And while the way that we practice and the way we deliver care has changed, our technology really hasn't caught up well enough. Obviously, we have EHRs, we've essentially digitized the paper chart, but our workflows are still very much on paper. We have all these workarounds that happen because the EHR doesn't do what we need to be able to stay on the same page with each other. And typically people are doing this in email and sticky notes and phone calls and messages, whiteboards in many places. Some of them are still in the EHR, but still very manual and unstructured, like I was mentioning, printed lists. We actually measured how much paper we were printing at Penn prior to creating this platform. This is just for rounding lists and handoff lists by doctors and nurses across the health system. We were printing 22 pages per patient per day. And when you think about how many pages that is, it's actually multiple millions of papers a year, just in lists of trying to coordinate with each other. And obviously that's inefficient, it's archaic, it's static, it's less than ideal. So our approach to this problem was to create a unified platform that brought all of these different piecemeal forms of planning and touching base and collaboration into one space. And instead of it being centered around the individual person carrying a piece of paper, it's really centered around the patient. So it doesn't matter who you are involved in the patient's care, you go to one place to figure out what's happening for them right this moment. And it, of course, doesn't replace texting or eliminate it. It doesn't eliminate calling. We need to still talk to each other and communicate in real time. But it significantly reduces the volume of interruptive messages that we get, because we don't have to message each other to say, hey, did you plate this order? Hey, did you see XYZ? Hey, are you going to work on this thing? We can see it all in this shared space. So I'll go through this next part a little bit fast, but really, this is something that has been through many different iterations over the last decade, and it really has three main functions. The first is data visualization. We use paper to access vitals, labs, meds. So we'll show that very quickly. The second is task management. So we can all see on the same page of what's happening, who's doing it, what's the status of those tasks. And then the third is really document generation, which we hadn't even thought of when we first built it, but we realized there's so much double, triple documentation and the things that we write on paper, the things that we message, and then the things that need to end up in the chart. So we built a way to actually generate documentation and content to put into the notes that the EHR is more complete. So starting with the first of data visualization, it's really all about getting the right data at the right time. So we're not hunting for information to make informed clinical decisions. So vitals, labs, meds, you can see these coming in real time from one or multiple EHRs. Showing this on a phone, but we found it was really important that we made this available within our EHR, either as a tab that takes up a whole page or in a sidebar, but that was really essential to be able to make this useful for everybody. And in the example that I just mentioned, for example, they would have actually been able to see that her hemoglobin had in fact been trending down for months and over multiple different admissions, and it would have alerted them to the fact that they needed to pay attention to that more. The second is the task management. So instead of everyone working off of these separate sheets of paper, everyone has one shared list for a patient to understand what needs to get done to make sure that things don't fall through. And again, in that situation, the attending could have written directly into CareAlign that she wanted to make sure hemoglobin got done before the patient was discharged. And then she wouldn't have had to worry about finding the intern to tell them. It would have automatically been on everyone's list. So the social worker, the nurse, the discharge coordinator, everyone would have seen that. And then finally, as I mentioned, you can, everything in the application is structured around diagnoses, or you can structure everything around diagnoses or a SOAP note so that you can say, generate a note or generate my handoff, generate my discharge planning items, and then put those into the EHR so you don't have to transcribe things written on paper all over again. And then just open it up from within the EHR, bring it into a progress note template that's already built within the EHR instead of having to start from scratch. So a quick note on adoption and usage. There's actually a paper published on this in the Journal of Applied Clinical Informatics if anyone wants to see more about it. But we really have pretty ubiquitous adoption across all of the inpatient services at Penn. This 94% is actually up higher now since we reported this, but all the inpatient services use it. About 90% of people feel comfortable using it within 3 days, and that's with the train the trainer model, and using videos for training. About 80% of people say that they saved an hour every day, and we have a significant reduction in self-reported errors. Usage is really interdisciplinary, which has been one of the most exciting things for us, because you can see here this is looking at unique users per week over 6 years, over our first 6 years at Penn. This is when we first launched just the data visualization and then implemented the task management and the documentation piece. And it really is, every different person involved in the care of the patient. Nurses are huge users of the system. When you look at who logs in the most, it's residents, trainees, advanced practitioners, but it really is interdisciplinary. And when we first implemented, we implemented on only half of our medicine teams, and then we surveyed the existing teams, or the teams using the existing platform versus the new one. Our team actually made the old platform as well. It was just the more typical one based on paper. Comparing the new system versus the old system, pretty uniformly, the residents and the teams felt like the new system was safer, they were more satisfied with it, and they would be more likely to recommend it. And just in terms of activity, to give people some context about how much it's used, this is looking at how many times people are editing information that they would have been writing on paper. On average, at our health system, about 50 times per day, people are making changes to a patient. So between tasks or one-liners or anticipatory guidance for handoffs or other things about the plan. So it's a lot of information that would be hard to pull together from multiple dozens of papers across a day. So last slide here, just saying, at least from a data perspective, before we hear from everyone on the call about their experiences, what people report is that it saves an hour a day. And I think it'd be interesting to hear what you, Nicholas and Carissa, think, since you probably never practiced without it. But at least in the beginning, when we implemented, people said it saved them an hour a day. 3/4 of clinicians have a reduction in self-reported errors, saying that they could each point to a time when it helped them prevent a mistake. And then importantly, that ends up in improved HCAP scores, patient experience. Patients say that they feel like their teams are on the same page more and saying consistent messaging to them. And then because of the documentation piece, we've actually seen an improvement in diagnosis capture, severity of illness, and case mix index. So that is the intro into the problem and our approach to a solution. I just realized I did that whole thing without letting you all. Oh no, we did do introductions. Okay, so how about I'm going to go to Carissa, because I know Carissa's in the hospital and may get called away. So Carissa, do you want to start with summarizing your experiences?
Yeah, definitely. Thank you. So I think I would start echoing everything you said. I definitely update CareAlign more than 40 to 50 times a day on my patients. And I think what makes the most sense would be for me to just go through and kind of describe my workflow of using CareAlign, and how I used it as an intern, and then how I use it as a resident now.
Sure.
I've never really been at a hospital, because I did med school here too, a hospital without this tool. So I think if I ever do fellowship or I'm attending somewhere else, I think it'll be very stressful. But I think the best way that I describe how I interact with CareAlign on an inpatient rotation, it's really the first thing I look at on my phone when I wake up in the morning before I even get out of bed. And then the last thing I look at, or almost the last thing at the end of the day. My workflow in the morning, typically as a resident or an intern, starts with, waking up before I have to be in the hospital. And then I'm a big alarm snoozer, staying in bed as long as possible. So I will grab my phone from my bed and just pull up CareAlign. And while I'm laying in bed trying to wake up for the morning, I will scroll through my list of patients And the kind of flow in our hospital is the night teams that are cross-covering the patients put all the night events in CareAlign. So if somebody was hypoxic and needed a chest x-ray, or if somebody fevered and got blood cultures, or if somebody wanted to leave AMA or any important information like that, it's in the CareAlign night events. So before I even get out of bed, I'm kind of thinking about my patient list and what events happen throughout the day, what I'm going to need to triage in the morning. I'll also be able to see from that list, you know, do we have any new patients that we got overnight? Am I going to need to go use Epic, our EMR, to read full notes, or am I just going to be able to stick with the CareAlign list? And then I take a quick look at everyone's vitals to see if there's any sick patient or anybody who got sick overnight that I'll need to swing by and see, maybe even before rounds. Then kind of walk into the hospital or ride the bus into the hospital, and then I might be kind of perusing my phone a little bit more. And when I get in, we actually don't do verbal sign out on old patients at Penn for the medicine resident services for most of our for all of our teams. So we'll get verbal sign out on the new patients, but on the old patients, we save so much time by just reading the night events. And if there's a night event that seems significant or something I'm confused about, I'll use the verbal sign out time on the new patients to ask the overnight residents a little bit more. I'll say, hey, I saw that this patient had this issue. Can you tell me more about it? But I think it really saves a lot of time there, and that sign out takes maybe 30 minutes. You're getting 2 new patients overnight. And then as I'm getting sign out on the new patients from overnight, I have my CareAlign checklist up. The night team will usually have already put tasks in for the day. So they wrote their whole H&P, but then, you know, they wanted me to call a renal consult in the morning, and they, you know, held anticoagulation, but they weren't really sure if that was the right decision. So instead of that being in the note, or it will be in the note, but it will also be in the CareAlign, it will be like resume anticoagulation with a question mark. So I'll know that's something on their mind. And then as they're signing out, I will be kind of going through and making edits and modifications to those tasks that they put in there. Then at that point, sign out's really done, and I have my tasks for the day. And if I don't have an intern, or if I was an intern, I can go through and prep all of my notes, and I have the day events from yesterday, the events from overnight that I just copy and paste right from CareAlign into my notes. And as I'm doing that, I'm going through each patient, I'm checking their CareAlign, like editing my notes, making a few tasks. And since I can pull them up side by side in Epic and in CareAlign, if there's any minor tasks like dose diuretic or make sure this person gets fluid, I can do those really short tasks without having to reference a paper chart or anything like that. If I am senioring, usually that intern will kind of go off and see all the patients in pre-round, and I'll sit down and do the same thing with each patient. And one of the nice things about the flow is that the intern has CareAlign on their phone. And so while they're going around seeing the patients, nurses are curating them and things like that, consultants are calling them, they're updating the CareAlign in real time with those calls and those curates, which is our kind of protected health information secure text messaging system. And they're updating those tasks, and then I'm just seeing them pop in as I'm kind of reviewing my CareAlign list. So I can see that, you know, they maybe called nephrology, and nephrology wants us to send urine studies, and that they'll see the patient later, but the intern doesn't have a computer to put orders on, so I can order that right away. And likewise, when the intern comes back after pre-rounding, if they're like, oh, I need you to place those orders, since I've kind of kept a running log of, we have a dot phrase in CareAlign that we use, that's dot day events, that anytime I do any task, I just update that. And so the interns, when they come back, they'll say, oh, Carissa repeated electrolytes and ordered those urine studies. And look, my task that said, you know, order urine studies for nephrology now says follow up urine studies because she edited it. And that honestly is the best way of communicating with your interns, especially when you're on a busy service for me, and the best way of us both being aware of what tasks that we've done. And right now, when we have new interns that just came into the hospital, kind of today was our switch day on service. So the whole morning, the thing that I was telling them over and over again was like, make sure you're constantly updating CareAlign. Like, that's how we communicate. Then we round, and we round with the attending. And as a senior resident, if I have a mobile workstation, I have CareAlign up and I am updating the plans for the day in CareAlign, changing around the tasks based on the attendings' feedback. When I'm doing my presentations, I never view my labs in Epic. I think it's a terrible way to view trends. So I'm always pulling up lab and vital trends on CareAlign. Even this morning, we had a patient with a creatinine kind of increase over the course of a hospitalization. And when we were explaining to her why she couldn't go home, we were just able to show her the creatinine trend in CareAlign, say like, look, you started here, now you're all the way up here and you only just came down a little bit. We need to see you really, and she's like, oh, and that visualization really helps. Or seeing longitudinal blood pressure curves or fever trends. So using that all during rounds. And then by the time rounds are done, the CareAlign that we start with in the middle of the day is so different than the CareAlign in the morning. And it's updated with all of those tasks that we've done during rounds. Oh my gosh, I'm very sorry. This is, I think, an automatic light situation. But we're updated with all of those tasks that we did during rounds, new plans of care. And then before conference, I'll run the list, either with myself if I'm just alone, or with the intern. And one of us will do orders and one of us will do CareAligns. So I'll be updating the orders in real time and the intern will be writing in day events, we ordered this and why we ordered it. And then I'll go to conference, and let's say it's a senior resident conference and the interns aren't there. They have this whole list of tasks that we just went through, and then we switch and they go to conference, I come back. We don't need to talk about what's been done. I just pick up with the to-do list where they left off. And so we'll run our list, updating CareAlign and placing Epic orders together a couple of times throughout the day. And then when we sign out, we're signing out to the night team. All of the events, the consulted renal said send urine studies, renal called back with Rex, they recommend giving like a liter of LR. That all is documented in my day events and my whole thought process. And then when I sign out, maybe renal wanted me to check a afternoon BMP and I'm signing out at 5 p.m. to the team that's going to be there until 7, or the overnight team. I put a task in the night event section of CareAlign, that says, 1800, check BMP. If creatinine above this, call renal. If not, do this. So that task is in there. And then as a night resident, when I'm cross-covering, I'm like, oh, I don't understand why they did this, or the nurse asked that in order. Frequently that logic is in day events that's already been recorded. And so, that's how we use sign out. We do verbal sign out at night. And then at night, if you're taking sign out, at least our version of CareAlign has a notes tool that just lets you see notes that you write to yourself. So each day I'm cross-covering a list, I'm adding notes about a patient that I can refer back to. And then, if I'm home, I sign out a little bit early. I can go in at the end of the day and say, I wonder what happened to my patients, just wanted to make sure everything's okay. And I can look and I can see how the day team that I signed out to modified CareAlign. And just comparing that to, at the VA, here we don't have that. We have CPRS and we have a Word document. And a Word document doesn't let you see labs and vitals in real time. You can't pull it up on your phone and update tasks on the go. You can only have it on one computer at a time. If 2 people update at the same time, there's an error message. Tasks will get missed or done twice. And really just kind of having a dynamic to-do list. I rarely look at Epic during the day, just if I'm clearing flags. I'm just constantly going back to CareAlign and updating that list. And then, things like attendings, leaving little notes in CareAligns if they see something like, you don't, sometimes just having random orders come back and you didn't place those and somebody else did, and you're like, why did this order come back? And but if the attending leaves a note and they're like, oh, hey, I just saw the patient this morning, they're in a lot of pain, can you order tramadol? Then, you can order that. And the nurse isn't asking you like, why'd you order tramadol? And you're like, I didn't order tramadol, like who did that? So having that layer of communication is really excellent and well. And I think overall—
Can I ask you, Carissa,
yeah.
I'm sorry to interrupt you. Can I ask you a question? Because I feel like some people might hear that and say, well, shouldn't that be a text message instead of, or a phone call?
I mean, it could be a text or a phone call, but your phone's going off so much already. And if it's urgent, sure, but your phone's going off all the time already. You're getting nurses messaging you, you're getting a bunch of calls. And I don't know. I think just seeing it there, if it's non-urgent, you'll get to it when you get to it. And again, I look at CareAlign so much that I see it almost as soon as I would a text message anyway.
Yeah.
And I think like ultimately, kind of, and the spiel that I gave my interns this morning when I was like doing goals and expectations is like, you know, CareAlign, I think, has a learning curve that takes maybe a day or two. But it really like decreases the cognitive load I have during the day. I don't have to worry if I'm missing tasks. I don't have to make sure I've communicated everything I've done with my intern. I just put it in CareAlign. They put it in CareAlign, and I know it's all there. And I don't really know how I would like kind of function without it at this point. It's so ingrained in my daily workflow, which is very task oriented as part of residency.
Thanks, Carissa. That was awesome. Nick, do you, and just everyone, in case Carissa drops off, that's because she's getting called away, as you could hear in the messages as she was getting it while she was doing all that. Nick, as a chief resident and your experiences, do you want to add that to that?
Yeah, absolutely. I think I can kind of, I mean, a lot of my experience is going to be somewhat of an echoing of, or kind of a summation of what Carissa has already said. I guess the one caveat with my own experiences is that whereas Carissa has done all of her training here, did medical school here, and then stayed on for residency, I went elsewhere for medical school and then came here for residency. And while a little bit different than, I mean, definitely like interface with patient care and the EMR differently, as a medical student and as a resident, I at least had an opportunity to just see kind of how workflow would work on an internal medicine service, or really on any other service, using other forms of kind of embedded signouts, for example, like Epic signout tool. Admittedly, I think there's certainly, with any new technology, there's a learning curve at the beginning of residency, and all of our new interns start and they're kind of like, what is this CareAlign? And but very quickly, I mean, people get adjusted to it and very quickly kind of see a lot of the benefits that Carissa had mentioned. I think from a chief resident standpoint, now that I've kind of done the 3 years of residency and I'm operating a little bit more at like a systems level, I can see very clearly that I think a couple of different domains where CareAlign, from my standpoint, has been wonderful is efficiency, which I know that Carissa talked a lot about, transitions of care, and then like error reduction. And there are a few other areas too that I'll kind of touch on, but I mean, Carissa went through in wonderful detail the kind of day-to-day, kind of moment-to-moment utilizations of CareAlign, and what that boils down to for our residents is it makes them more efficient. And I think that, and the way in which I see that manifest is that people are able to attend noon conference. People are able to get tasks done before noon, or able to discharge patients before noon, even though that's not goal number one. It still allows them to kind of be efficient members of the healthcare system, because they're just they're not kind of writing something on paper and then losing track of what they've written on paper, and everything is kind of centralized for all aspects of the healthcare team. So dispo isn't held up, things are able to get done quickly on rounds, et cetera. And I think one of the segues out of efficiency is that I think, or one of the effects of the efficiency is that it improves just, I think, burnout among the healthcare team too. That you're able to leave the hospital maybe a little bit sooner than you otherwise were, or you're not getting bogged down with running a list 8 times a day, and kind of those, I think, more those tasks that, for at least me as a physician, aren't quite why I went to medical school in the first place, but that I think characterize inevitably aspects of our day in the hospital. And then Carissa had mentioned both her role as a day resident and as a night resident, and the transition between the two. I think CareAlign is absolutely instrumental in how we transition care from day teams to night teams, or in between levels of care, so from the floor to the ICU or vice versa. And I think that's one of the phenomenal things about CareAlign versus prior tools that I've used embedded in other EMRs. Is just that we don't, because of how CareAlign presents and delivers the information to us in the morning, as Carissa mentioned, the night float residents aren't here for an hour and a half in the morning, signing out patient by patient their experiences overnight. CareAlign presents information in a visual way where you can very quickly and easily see objective data, subjective night events, and it doesn't rely on kind of a verbal report of all of that information, which kind of feeds back into the efficiency picture too. And then error reduction too. You're just seeing a lot of the same information as Epic presented in a different way. And in a more helpful, I think, more clinically useful way. I use Epic as the example because that's the EMR that we use here. But I think really any major EMR used by other institutions, CareAlign displays labs in kind of the traditional bracket that we're used to. It gives you really nice access to trends. And it's kind of a second set of information, or a primary set of information, honestly, where there are just fewer gaps, fewer holes in a Swiss cheese model to make error. The only other things that I'll add to this, I know that Margot is going to talk a little bit more about the educational benefit, particularly as it interfaces with medical students. But I will say from a program standpoint, from a recruitment standpoint, it's been a really wonderful tool for us. We have an opportunity to kind of show de-identified versions to medical students. And for people that are interested in informatics, it's kind of in and of itself is a very intriguing, attractive frontier. But then for people that are just, I mean, people are into it, I guess, and the way that it displays data, the way that it serves as a sign-out tool, it's been a very nice thing for us to use as part of our recruitment spiel each year for incoming residents or prospective applicants. There's a huge educational benefit to it in the way in which you can use it as an educational tool that I think both residents and attendings use. This might be a good segue to kind of lead into Margot's thoughts on it from like an attending perspective. I am kind of at the crossroad of resident into attending. I do work as an attending as a chief here, which is scary in and of itself, but not actually. But I haven't yet had an opportunity to be an attending since finishing residency. And so I can comment on the educational aspect of it versus wait for Margot to take this.
Yeah. Margot can maybe before we go to Margot, Nick, do you want to say as a resident, because so much of a resident's time is spent working with students and making sure that they're getting a good experience. Yeah. How could you speak to maybe how medical student, how it does or doesn't help you integrate students into the team and help them really feel like part of the patient care?
Yeah, so I think a couple of different ways. I think I think first and foremost, one of the issue, thinking back to when I was a medical student, I think it's very overwhelming. It's very difficult to figure out. It's very difficult to figure out how to synthesize all of the information that you're seeing in Epic. So how to think about somebody's one-liner, how to think about somebody's labs, somebody's lab trends, for example. I think kind of change over time is something that is important for medical students to start to recognize. And I think it's admittedly a little bit hard for medical students to be able to synthesize all of that information in an efficient way and kind of understand what's going on for their patient. So I think that from that standpoint, as a resident teaching to learners like medical students or interns, I think it's a really nice tool for help with synthesizing that information. There's an opportunity to work on a one-liner as a team to view lab trends, to kind of view what we're doing as a team. And I think that's the other area where it's helpful is there's a way, because it's accessible to everybody on the team, there's a way to actually assign tasks. And so rather than just say, put in CareAlign on rounds, call family for this, or read about this, it's helpful where sometimes you can actually assign that to folks on the team. There's a color coding option in CareAlign. That's specifically how I've previously done it, where you can actually color code tasks like highlighter colors. And that's traditionally how I've always sort of at the day one, when I'm setting expectations with my team, I've said, okay, you're going to be pink, you're going to be blue, you're going to be green. And whenever something comes up on rounds, or if there's a task that needs to be done, I'll color code that. So that way, when we're running a list later, it's a way to engage everybody on the team. And then the final thing too, is you don't have to just use it. So there's an example up on the screen of from the attending, but there's an example of something being color coded, and then there's also a yellow color that exists. So I'll assign sometimes colors like that to members of the team to really engage everybody. You also don't have to put tasks. They're just free text lines, and so you can actually put little educational tidbits, and that's the other way in which I've tried to engage medical students and interns is if we don't have enough time to talk about sort of maybe hemolysis or just I'm thinking of things off the top of my head, I can throw a like very brief paragraph in there about what I was going to try to distill down on rounds, but obviously didn't have time for, so that whoever's taking care of the patient can come back and look at it later.
That is awesome. I love hearing about totally new ways of using it that we would have never thought of. So that's really cool. Thanks, Nick.
Absolutely.
Margot?
Yeah, I can build off of some of what Nick said and then offer a few other pearls as sort of the attending role and as the educational role. I think two of the things Nick said I 100% agree with, one of which is the kind of color coding of tasks. I think particularly for clerkship students, they really struggle to learn what their role is on the team and how to get involved in the team. And as the interns get more efficient, a common complaint I hear is that the students feel like all the tasks are done by the end of rounds and they don't know how to help. And so I've told many of them to talk to their teams about flagging things for themselves in CareAlign or working with the team to have a color code so that they can say, hey, I'm going to take this on, and they can loop back to the team to say, hey, I completed this task and this is what I found, which I think helps a lot because otherwise there's a lot of duplication between medical students and interns and the time is not saved the way that you might hope it would be. So I think that's a huge benefit to students in particular. And then the other point Nick said that I think I really find to be valuable is including teaching points in CareAlign. And I think this benefits the students, but I think it also benefits the senior residents that are sort of learning what their leadership and teaching style will be. I found for a lot of residents who maybe either are so busy with tasks on rounds that they can't kind of get themselves engaged on an educational level for the broader team, or who just might be more introverted styles of leadership where they don't want to be interrupting and jumping in on rounds. CareAlign can be a great option for them to include either novel teaching points of their own in the afternoon that they can attach to however many patients they want that the team can review and I can review. Or even I've had people just sort of summarize what teaching points came up on rounds already. So it's not even really adding work to them. It's just summarizing, hey, here's some interesting teaching points that we talked about on rounds today. And I think that does a few things. It helps the teaching style of the resident be developed. It also helps with one of the big issues we see on resident teaching rounds, which is just constant interruptions, and particularly for interns and sub-Is being pulled left and right and missing parts of rounds and missing part of the educational concepts in rounds. And so if the senior resident is highlighting those points so people can look at them later and after the fact, I think that goes really far to making sure everyone's getting some educational content out of rounds, even if they were running around at a rapid half the time or they were doing a new admission or discharge. They're still able to look back at the end of the day and say, oh, right, this is what we learned, or, oh, I missed that. Here's how I'll learn about hemolysis where I might not have seen it otherwise. So I think for interns and for senior residents in particular, that can be a really valuable part of CareAlign. The other parts that I find to be helpful as an attending, one is being able to provide feedback on parts of the resident kind of skill set that I otherwise wouldn't see. So thinking about their handoffs and their clinical reasoning, I think sometimes you see a lot of that in how people are utilizing CareAlign as a handoff tool. So Nick mentioned sort of having a team one-liner. You know, I've had teams where that one-liner is wonderfully updated every minute. And I've had teams where I look back and a few days go by and it really hasn't been touched since the first day of admission. And that's a great place to give the team some feedback to remind them when you're on nights, that one-liner is really, really important to you when you're running into an emergency. Similarly, I think frequent feedback I give is about kind of updating neurologic exams in CareAlign. That's something that tends to fall off a bit, but can be so important. I remember being a senior resident on nights and we had a patient who kept getting stroke alerts for a known neurologic deficit that we all knew about during the day team. And if that's updated in the handoff tool, that saves the patient a lot of stress. It saves the night team a lot of stress. And so I think being able to review that portion of things, which really you would not see as an attending otherwise, is really, really helpful, and also gives you a sense into how people are contingency planning as well, which for both the interns and the sub-intern learners is a big skill set we're trying to teach them. So I think seeing that in CareAlign, there's sort of some FYIs of, hey, if this happens, do this, or if this happens, here's my first thought of what might be causing it. can be really helpful as a way to sort of teach again outside of rounds, which can be really busy. And then the last thing I'll mention is, as an attending, and Nick will experience this soon, particularly as a new attending, moderating your level of supervision for learners is something that I at least struggled a lot with. It was hard to step from the resident role to the attending role, and to not be over involved or be messaging constantly with new things and texting constantly. So I find that CareAlign helps me as a supervisor a lot, because I can look at it in the afternoon without really bugging the team or making them discuss things 3 times. I can just take a look and say, oh, great, they saw that new blood culture result came back and they already ordered the echo. Or, oh, they talked to the family and this is how the goals of care have adjusted. Or if there's things that are not noted and I've given it a suitable amount of time, then I might message them either in CareAlign or texting and say, hey, not sure if you saw this result. I didn't see it mentioned in the CareAlign, wanted to make sure the team was aware of it and can build off of it. So I think it goes very far to balancing sort of resident autonomy and supervision and safety in a way that isn't burdensome, I think, on the residents. And certainly the feedback I've gotten as I've started to use CareAlign in that way is that it gives the senior resident a lot more autonomy, which is what I want them to have. And it's my own new attending nerves that's making me reach out to them. And I think CareAlign helps you kind of moderate that a bit more. And it also gives me a sense in terms of sort of time saving and efficiency. If I know my team and I trust my team and they've been doing well and there's nothing major going on, often at the end of the day, instead of running the list and making them stay an extra 20 minutes, I'll say, hey, I reviewed CareAlign. If there's questions you have that you want to talk about or a new admission, give me a call. If not, feel free to sign out when you're going to sign out and I'll let you know if I have questions. And that helps a lot for, frankly, my workflow, but I think also for the resident workflow, because otherwise they're rehashing running the list over and over again. So I find it really helps on the resident services sort of across the educational and sort of operations efficiency-based missions that we're always trying to balance as hospitalists, and that can be really, really challenging to balance. I think it gives you an extra tool to sort of support you and the team as you go forward.
That's awesome. Thank you, Margot. There's some questions that have come in and definitely certain things that I hear from people as we talk about it and are interested in asking. One of them is, you all mentioned, like, there's been a lot of talk about tasks and managing tasks and updating tasks. And I think for places where they're using paper or they're using a Word document, sometimes they feel like that looks like more work. And so a common question, and one of the ones that we got is it really creating more work for you to have to keep track of all of these tasks in another place when the EHR already feels like so much work?
Nick, do you want to start? Because I think it probably applies more to residents, but I can comment after about sort of the other view.
Yeah, I recognize that was a question that I had myself at the very beginning of residency, of like, I feel like I'm documenting a little bit in Epic and then also documenting things in CareAlign. I think first things first, just like interfacing with an electronic platform versus like physically handwriting something down is quicker in today's age, whether you're typing out something on your phone or you're writing or you're typing something on a desktop itself. And then I also find that just the way in which CareAlign presents information as well, I feel like there's a lot of clicking through different pages, different tabs to try to recognize trends or to try to see new results, to try to get a sense of like what this person's one-liner is. There's a lot of just, I think, clicking that occurs in most EMRs, and the time saved with not having to click on CareAlign, where you can open up something, you can just immediately start typing into a task list for the day, or you can like very easy without clicking anything, see a new result, see all of their like most recent CBC, BNP, et cetera, see a one-liner, et cetera. And so I think that was whereas I agree that maybe it would feel initially like you're double documenting. I think that any potential efficiency loss with that is for sure regained with just how little you're having to kind of click on multiple different things, have multiple different tabs open, because everything is just all in one place.
I'm going to ask a follow-up question to that before you answer, Margot. Is the things that you're writing, do you feel like you would not be writing them on paper? otherwise? Or is it just you're writing it in CareAlign instead of writing it on paper?
I think it's a mixture of both. I think you're able to, because I think it's a good communicator, and like it's a good communicating tool between members of the healthcare team, which paper is not going to work for that. So you're able to like write tasks that you would write on paper, but you're also able to communicate like me from a resident, or me to a resident, or me to an intern, or to an accepting ICU team, for example. Yeah, so I think that you're writing more than what you would normally write on paper.
Yeah, I'll build in just two ways. I think one thing, and I'm a paper liking person, but I find with how collaborative inpatient care is, which is, where I think this is used the most, and as a hospital, it's certainly the only way that I practice. There's so many members of our team, not even thinking about non-providers, but just PAs, nurse practitioners, and residents and students, that I find CareAlign, the paper list is not helpful for that, because we all have a unique list. And as things get updated, there's no way to share that without wasting a lot of your time or physically handing things back to back. And so I find in the system we work in that's so team-based, CareAlign allows you to have this shared list that just doesn't exist otherwise, or at least hasn't existed in the EMRs that I've used. And the immediate updating and ability to see it from different venues, whether you're in the room with a patient or running to the emergency room or not having to be back in a call room with someone to share information, I think helps a lot, from efficiency and also from just clarity. Again, kind of thinking about avoiding that duplication where either two people are doing a task or no one's doing a task. It's very easy with CareAlign to say, oh, great, this person already did that. Even if that person's now off at conference or in the patient's room, you still have that communication, and you don't have to wait and have those delays in care when you're waiting to get someone back to actually physically ask, hey, did you do this task? Or what was the outcome of the task that you did?
Great. That's awesome. One of the questions I was going to ask is, and that someone posted to me a little bit ago, is everything, it sounds like all the things, all the vitals, the labs, the meds that you're talking about in CareAlign, they all exist in the EHR. So is it really that much more helpful for you if all that data is there anyways? I know you touched on this a little bit, but just wanted to ask that since that was asked. I'm going to call on Nick since you both are being polite to each other.
I think it's the way in which the data is presented. I'm not sure if there was a slide on, or if you had a slide that showed some of the way in which the objective data is presented, but so I think that it's for me it's that it's easier on the eyes than I think Epic is, and the way that it displays even basic labs. It lists all like recent labs. You can see too, beneath the brackets of common labs, there's a list of other less common labs where, let's say, a bank level may come back or microdata may come back. You can see it's stratified by micro and by pathology too. And you can organize that by either time at which it's drawn or time at which it's resulted. So if you do it by time at which it's resulted, you're picking up kind of the most recent things that have just come back. If you click on any of these things, it brings up the window that's over there on the left-hand side, which is a trend that's showing you in this case that somebody's hemoglobin has been dropping. The other thing that's nice about CareAlign is that it's color-coded. So anything that's within normal range is green, anything that's abnormal is red. So it's very eye-catching. I think it's all of those features that it's easier on the eyes. You can digest important information very quickly and also see trends very easily. That makes this a better tool for seeing data, which is a crucial component to sign out and shift handoffs than it is on Epic.
So this question came in and it really relates to the Epic handoff tool. Have either of you used the Epic handoff tool anywhere?
I used it probably 4 to 5 years ago.
Okay, it's the same.
I went to Vanderbilt in full disclosure for medical school.
Let me read you the question, Nick, if you don't mind. It says, I had to join late, so I may have missed it, but what are the pros and cons as compared to the shift handoff tool in Epic? I feel like this has some similar functionality and is integrated, meaning the Epic handoff tool is integrated.
I think that the Epic handoff tool probably exists a little bit more in turn, like for handoffs specifically. And I think that CareAlign does much more than that. From how it displays data to, I think, accessibility for, so in addition to just the Epic handoff tool, I know exists as a way to kind of provide updates on day events with tasks that need to be completed. But CareAlign more so functions with that, but it's an easier, I think it's easier than the Epic handoff tool for if there's an acute decompensation, there's more data available to you than what exists on the Epic handoff tool. It also allows you to, as we mentioned, I know that the person that asked the question joined a little bit late, but we were talking about some of the like educational benefits of CareAlign, where you can color code tasks and assign tasks out to multiple members of the healthcare team, multiple levels of learners. You can put educational pearls in it. There's a little bit more functionality to CareAlign as like a team communication tool than just this is what we did today. These are the tasks that need to be done.
Yeah, and a couple things I can add, since before we built it, we heavily investigated in what Epic's handoff tool could do. One of the biggest differences is that only one person can access the Epic handoff tool at a time, or at least only one person can edit it at a time. Whereas in CareAlign, you can have countless people editing the same thing at the same time. So pretty often during rounds or at different times in the day, you'll have the resident, an intern, and attending all looking at the same patient in CareAlign and adding to-do items or updating information, which otherwise you wouldn't be able to do more than one person at a time in the Epic tool. As you mentioned, Nick, you have mobile access to actually work on and edit that information. So if you're not in hyperspace, you're not forced to just write on paper and then update it later. I know that with Epic's iPad app, you can do that, but it's pretty rare to have iPads everywhere in health systems, as I've seen, at least for large medicine teams. And then another thing is that the Epic handoff tool is team specific. So every team has their own and they can't really share or see each other. So a good example of this, if a patient goes from the ICU to the floor, you're starting off with a new handoff, you have to start all over again, you have to write everything all over again, and you can't see each other's. Whereas CareAlign is really structured around the patient, and it travels with the patient regardless of where they go, regardless of which team they go to. That could be surgery to medicine, it could be floor to ICU. And so with those, cross service transfers, it really helps as well. I can tell you, when we first implemented, one of the things we heard a lot from specialty services was, I don't want the primary teams to see what's in my handoff, because consultants can also use it. And then pretty uniformly, within a couple of weeks of using it, each of them would say, actually, no, this is great, because there were all these things I didn't know the team was doing, or I realized that my note didn't clarify something well enough and they would have made a wrong decision had they not seen it in the handoff. So that increase in transparency between teams has also been really beneficial. Great. Well, I don't have any more questions in the queue, and we're almost up on time. So I want to thank everybody. Nick or Margot, if you have any last things you want to say, please feel free. But I learned and appreciated hearing from everybody about how they found this helpful. Great, thanks.